So this is a 65 years old female known case of diabetes, hypertension, and she is a chronic BD smoker. So she presented with the inferior wall ST elevation MI, and this is probably second day of her chest pain, and she was thrombolized outside and then they referred here. You can see there is a complete total thrombotic occlusions and probably organized thrombus. This is the right radial root with the Tiger catheter, and this is the RCA. This is a spider view, and left main is okay. LAD and L6 minor lesion were there. Non-significant lesion. This is the RO caudal view, and this is a cranial view. You can see some collaterals are getting developed. This way we can see some septal collaterals are going to the RCA. So that is what she told, only 2 days. So after all clearance, we took up this patient, and this is right radial root with JR catheter, 3.5 into 6 French, and this is a BMW PTCA wire. And you can see how I am negotiating this wire, and in hope of getting it crossed, but it was organized thrombus and very hard thrombus. And see, almost around 10 minutes I negotiated this PTCA wire, but I could not cross the lesion. You can see in this lateral view there was a hope to cross the wire with this workhorse wire, but it didn't. I had to change the wire. I upgraded it to the whisper wire, and somehow after some time this whisper wire got crossed. So you can see the shape of wire, and whether it is in the PDA, PLV or some small branch, we don't know. The flow hasn't come. So there was no flow. So in hope of getting flow, I decided to do the balloon daughtering. Balloon daughtering is the to and fro motion of the uninflated balloon in hope of getting some flow. So even after balloon daughtering, there was no flow. So I decided to do the predilatation at the place where there was a lesion. So after predilatation at the place of lesion, I got some flow, and this is the flow you can see. So this is the thing. Now I got a flow, but a hard thrombus was there, and is probably a place of plaque rupture, probably calcified plaque, calcified lesion, fibrotic lesion, thrombotic on the top of that. So you can see that my wire is a whisper wire, and my wire is in very small branch of RCA. So this is dangerous. So I wanted to remove this wire, and I wanted to place the wire in some bigger vessels, either it is a PDA, PLV. So I tried and I negotiated. So after this, I have given terifibin, this Nicoran and everything, but flow is like that only. You can see the probable place of plaque rupture, and in the mid RCA. There's a thrombotic vessel right from the proximal RCA. Then again we did the predilatation with some bigger balloon. Even after that, this is the thing. So this was almost 2.5 balloon. We predilated it. This was a NC balloon, predilated at around RBP pressure. So this is a picture. Then we decided to put a stent in that portion where the plaque rupture. So the stent is 3 into 28. So deployed. The stent is deployed at around RBP was 16, at around deployed at 14 atmospheric pressure. So I was not happy with the stent inflation. So we did the NC with 3.5, and the second stent we deployed at the proximal RCA and we overlapped with earlier stent. Second stent was 3 into 32. So not happy with the result, so I did the post dilatation with 3.5. So this is even after doing aggressively post dilatation. You can see this is sort of result. So this is a still image to show the what exactly, and we accepted this result after doing 2 times dilatation with 3.5. This is the result. So we accepted it, and this was the angioplasty to totally thrombotic occlusion, calcified. On top of that, it is a thrombotic. So this is angioplasty to RCA. Had it been with imaging, then we would have come to know what are there exact. But